Welcome to Redefining Medicine, an intimate and personalized program that illustrates a different side of the practice of medicine. Our in-depth conversations will focus on the physicians and practitioners who are redefining medicine through their integrative, functional, and holistic approach to health and well-being.
We are happy to welcome Dr. Barbara Fisher, a neuropsychologist, board certified in behavioral sleep medicine. Welcome to Redefining Medicine.
Thank you.
So tell us a little bit about your background.
So my background is in neuropsychology. I've been doing that for over 30 years, testing and evaluation. ADHD has been a passion of mine, as well as dementia and head injury. And so I've been doing that testing and also involved in non-medication treatment programs for ADD, ADHD, as well as memory and executive reasoning.
And you wrote a book on ADHD, correct?
It actually was my fourth book. I've written 4 books on ADD, just introducing it. Initially, we came up with a testing version. So I came up with a way to evaluate ADD, ADHD using neuropsychological testing, and that was developed again over 30 years ago. And so the first book was really to document the reasons for my testing, and so it was all research. There was 80 pages of single-space references to document why those tests were chosen and why they were appropriate. And then the next book was more of a easy reading for the lay population to be able to understand what ADD was. The third book was ADD and sleep, and this last book is the results of a research study that was over 20 years and the statistics from that research study. And so there's a lot of information. So statistically, a person can open up the book and read about a certain symptom and where was that seen and how often was that seen, males versus females, what age, and really tracking the developmental pattern of ADD, ADHD.
And so your most recent book is the one that is what you think about ADHD, it isn't?
That is correct.
Yeah. So give us an idea of what are some of the misconceptions that people have about this condition.
So the problem is ADD is one big bin. And so the child shows up at 3 years old and they're out of control, and the first thing is, well, I think he has ADHD and I think he's hyperactive, let's pop him on some medication. And at 5-year-old, the child is still not sitting in circle time and they still look pretty overactive. Let's make sure they're still on medication, or let's put them on medication. And then at 7 or 8-year-olds, they're not reading, and so now we look at, okay, I think we're talking about ADD. The problem is that they look at everything as ADD. So later on we find out, no, the child wasn't really ADD, they were actually part of autism spectrum. No, the child wasn't ADD, they actually had one big sleep disorder that was affecting the brain. No, the child's not really ADD, they had a head injury that everybody forgot about, and that manifested in the symptoms of ADD. Or the child was very anxious and that showed up as overactivity. So there's so many reasons why you could have symptoms that look like ADHD and they may not be, which is why obviously I advocate the gold standard is to do neuropsychological evaluation. It's not an IQ test. You're not really measuring IQ. You're measuring different aspects of attention, and that's why I advocate that. At this point in time, so is the rest of the community, because now in Michigan you have to evaluate for ADD. You can't just walk into a doctor's office and say, I think I have ADD, I have these symptoms, and you'll receive a script. At this point in time, you need to be evaluated. So in my opinion, diagnosis is really the key, and that's always the first bounce, because you can't treat what you don't know. And the more that you know, the better your treatment and the better your odds that you're going to be successful. So what we do is we do an initial diagnosis for ADD, ADHD, and if we find that is the whole picture, and we don't have any other symptoms that we're seeing. And so if I'm seeing symptoms of possible sleep disorder, there's mouth breathing, snoring, any sort of paradoxical breathing, then we might do a little memory screening. But if it just looks like it's garden variety, inattentive ADD is the whole 9 yards, there's nothing in the history, then we'll move on and we have 2 non-medication treatment programs, and sometimes medication may be an option as well, which we have on site at our facility.
So give us an idea of the non-medication protocols.
So we have two non-medication treatment programs. The one we've been doing for over 15 years, and that's a movement program. And so on pre and post testing, we see a difference on neuropsychological testing in areas like distractibility, slowed cognitive speed, the visual spatial issues that lead to the reading difficulties and reading comprehension, as well as information processing. And we always see a difference. We see more of a difference when there's not another disorder involved. And then the other program that we brought in recently is neurofeedback. Neurofeedback has an efficacy 5 rating by the American Academy of Pediatrics. And we find that it's very good in augmenting the program. I don't see neurofeedback for ADD as the only treatment. I think that it's very helpful in terms of treating the anxiety as the comorbid disorder associated with ADD, but we do see it being a wonderful, wonderful way to augment the treatment that we're already doing of the non-medication treatment program. So there's been several case examples where it's made a really big difference.
So what are some of the issues with medications?
So I'm not really allowed to opine on medication. I'm a psychologist. However, what we have seen in terms of my experience that I can opine on is there are some side effects associated with the different medications and when people come in. And so as a result, a lot of times people are really looking for a non-medication treatment approach. And again, it's different for everybody. The point is really that ADD is not a bin. It's an individualized genetic disorder that's passed down. We see ADD and anxiety come into the world together, and you have to just separate it out for every individual. What's ADD? What's anxiety? What's sleep? What else is going on? And then where is the treatment going to be? So you may have an adult come in and they've got a severe case of ADD. Are you going to wait for the treatment program to work, which is going to take about 2 months? Or are you going to suggest to them that they may want to see their physician and look at medication? You're going to suggest both things to them. Let's say you have a child come in and their scores are basically in the average range. Are they really going to need medication? Well, not from a testing perspective. That doesn't mean that the classroom might be different, and the parents can talk to their physician or pediatrician about that. However, the first bounce for them would be non-medication treatment, because on testing, it's not looking to be as much of a problem. But it's important to recognize that what you see on testing may not be in the real world. So at the end of the day, you just want to separate out your variables and get a very clear treatment plan, which may or may not include medication.
Mm-hmm. And I would imagine a lot of adults come to you having never been diagnosed when they were children. Maybe they were just called hyper or whatever, but they realize that they've got some issues and they're trying to figure out what's going on.
And that is correct. And what we have found in our research is that basically you have individuals who are very bright. The worst that the attention symptoms get is within the average range. So they're not going to be identified in school because they're going to get by. However, as life challenges heat up, whether that be college or whether that be a career change or whether that be they no longer have a secretary to take over the responsibility of completing the paperwork, or stress, then the ADD surfaces, or sleep. And at that point in time, then they come in, I think I might have ADD. And it's life-changing for them to be able to have a medication that they can take, or our non-medication treatment program. So in 1993, we were in Ann Arbor at the first conference for adults for ADD, and we thought maybe we'd have a couple hundred people. We had thousands show up. We were all shocked. Like, what are all these people doing here? And it was amazing. And it really opened up to the adults, like, well, maybe ADD is not a childhood disorder. And today the statistics are 50 to 80% of what we see in childhood persists in adulthood.
So you are now the clinical director at the United Psychological Services. Can you tell us a little bit about that?
So United Psychological Services is our facility, and we have over 24 therapists, clinicians, PhDs, who are providing different services, and everyone has their own niche specialty. We're a full-service behavioral health as a complement to the primary care physician and the specialties. And so we are a Blue Cross medical home. which may not mean much to people who aren't in Michigan. However, what that means is the primary care is at the center and we're the specialty at the spokes. And basically the idea being that we are providing all the behavioral health that's needed, whether it be medication, non-medication treatment programs, anxiety, depression, all of your psychiatric disorders, as well as your neuropsychological. So we have two non-medication treatment programs for attention, and then we also have non-medication treatment for attention and executive reasoning. We have a big outreach program for dementia, catching dementia early, and we have found that treatment has been successful in improving memory function and shown that on ongoing research studies. And we also address brain injury as well.
So dementia, is that the same bucket or bin as Alzheimer's, or is that a little different diagnosis or category?
So dementia is the big word that covers over everything, and now we refer to it as mild cognitive decline, and that's the entry level. And we're really trying to target people in between their 50s and 60s because that's when things start. Alzheimer's, from my perspective as a neuropsychologist/psychologist, is that we really see the true Alzheimer's a very small portion of the time, and most of the time it's related to cardiovascular disease and all kinds of other different issues, of which we're learning at this functional medicine workshop of all the different things that can affect brain function. That is what we're seeing in terms of graceful aging or non-graceful aging.
Mm-hmm. And I was going to ask you, you've been involved with AFREM since 2006 or so?
I've been involved with functional medicine for a number of years and have also attended the modules at various times as well.
And so what's your motivation for that? What are you learning and what are you hoping to get out of these different symposium and seminars and such that you go to?
Well, I do functional medicine myself personally, which I think has been an amazing change in my life and have been doing it for, I'm going to say, at least 20 years or more. However, I think it's very helpful with patients in terms of being able to refer them to the individuals that have completed the fellowship. So I think it's very helpful for patients to be able to refer them to the physicians or different practitioners that have completed the fellowship program as an added way to be able to address different life factors and to age gracefully.
And so you're actually part of the faculty now with AFREM, teaching Module 3, Neurology?
Well, I'm very honored to be doing a workshop on ADD, ADHD at this fellowship program and being able to present what I've seen with over 30 years of experience in the field of what ADD, ADHD is, and hopefully that will be helpful to have an understanding when seeing patients that appear to have symptoms of this disorder.
Mm-hmm. And I know that after these modules, you're often, the presenters are often cornered by the doctors and they have a bunch of questions. And what kind of feedback or questions have you gotten from these practitioners that gives you a better understanding of what their understanding of ADD and ADHD is?
I think the most important thing, and hopefully I'm answering your question, would be to really understand that what we think isn't, which is, again, the name of the book. So I think the most important thing to understand is that what can appear ADD may not be ADD, and that there can be other disorders. And that's where the first bounce is evaluation. And that's why the different physicians in the area and pediatricians refer to us to do an evaluation and then look at the other issues that can have such an overlap with ADD, ADHD. The number one, of course, is sleep. But that's followed by any sort of an injury that has taken place. People fall off a table and they bang their head and we don't think anything about it. Or I've had people come in and there was a skull fracture and they didn't realize that that was an issue. And so there are just so many other complications that can occur that we think is ADD. And it's not that the ADD is not there, it's just not the primary factor. And so what's important is not to treat it as the primary factor when there are other issues going on.
So it sounds like the takeaway here is let's get a correct diagnosis and proceed from there.
Yes, and I think that's really the place that neuropsychological testing has. And our testing battery is only an hour and a half because we are looking for, do we have symptoms of attention or not? In the old days, we used to do the IQ, but that was very laborious. And at the end of the day, what were we really looking for? And we found that it's much easier to just do this hour and a half of attention testing. Do you have ADD? Do you not have ADD? Which, again, we've researched and proven through time is a valid battery to do. And then move forward from that with what you see and separate out the variables.
Well, thank you very much. We appreciate your contributions, and thank you for joining us today.
Thank you.